on pulmonary rehabilitation in COVID, our experiences in Bangladesh. Basically, you all know this pandemic disease is very much associated with high mortality as well as morbidity in terms of particularly creating more agony to the society. And role of rehabilitation, particularly pulmonary rehabilitation, is very much important regarding reducing mortality as well as morbidity. And in the state of post-COVID state, the role of rehabilitation is much important than in acute stage as well. Today's webinar will be chaired by Professor Akim Salik, who is the coordinator of Cardiopulmonary Rehabilitation Studies Group. And our today's speaker is Professor Monirul Islam, Professor and Head Department of Physical Medicine and Rehabilitation, Sir Solihulla Medical College and Hospital. And today we have very experienced and they're distinguished experts in different disciplines, including internal medicine, Professor Sohail Mahmoud Arafat, Chairman, Department of Internal Medicine, Bangabandhu Sheikh Mujib Medical University. We also have Professor Harisul Haq, Head, Heart Failure and Rehabilitation Unit, Department of Cardiology, BSSMU. We also have Founder, Chairman of Respiratory Medicine, Professor A.K. Musharraf Hossain. And we also have Professor Taslimuddin, Chairman, Department of Physical Medicine and Rehabilitation, Bangabandhu Sheikh Mujib Medical University. Moreover, we also have, we're very happy to have Professor MD Monirul Khan, Professor and Dean Nursing Faculty, Department of Physical Medicine and Rehabilitation, Bangabandhu Sheikh Mujib University. We also have Professor Muzaffar Ahmed, Professor of Physical Medicine and Proctor of the University, Bangabandhu Sheikh Mujib Medical University. And we also have Professor MD Shahadat Hussain Ripon, Professor of Physical Medicine and Vice Principal, Shoaib Sohrawardy Medical College and Hospital. So I think we should not waste our time anymore, and we should go for the presentation. And for this region, I may request Professor Monirul Islam to deliver his keynote speech, please.
Professor Monirul Islam, please proceed with your paper.
Thank you, everybody. Today, our topic is post-COVID-19 respiratory insufficiency, our experience in pulmonary rehabilitation. Next slide, please. Hello. Thank you. Actually, coronavirus disease 2019 or COVID-19 has spread worldwide and has become a global public health emergency. Since these patients suffer from various degrees of respiratory, physical, and psychosocial dysfunction, psychological dysfunction, pulmonary rehabilitation is equally important in management of both admitted. We have very minimal experience of this disease, but the follow-up studies of shown that after discharge, patients with severe acute respiratory syndrome, that is SARS, can still suffer from symptoms such as restrictive pulmonary dysfunction, palpitation, hand tremors, exertional dyspnea. All of these affect their daily activities and impair their quality of life. Next slide. Next slide. Next slide.
Professor Kodjo, please.
With our experience of the new disease COVID-19, we have seen that similar symptoms like SARS are observed after discharge of COVID-19 patients who suffered from severe lung involvement. Based on the frontline expert consensus and references, rehabilitation specialists in worldwide have developed respiratory rehabilitation guidelines for patients with COVID-19. This is a very provisional guideline, I should say, because our experience is much limited now. We have seen, you have not treated many patients so far. Here I am going to present and share the experiences regarding pulmonary rehabilitation of some of our COVID-19 patients who survived from the extensive lung involvement. Extensive or less involvement, but involvement of lung. We think this experience will help us to construct a practical and feasible guideline of pulmonary rehabilitation of these patients in our setup. Next slide, please. Next. Next. Thank you. So what is pulmonary rehabilitation? Pulmonary rehabilitation refers to the individualized rehabilitation treatment of patients with chronic pulmonary disease after a detailed assessment. With exercise training as its core, pulmonary rehabilitation comprises comprehensive interventions which includes psychological support, nutritional support, postural drainage, education, and behavioral changes. Actually, the patient who suffers from severe lung damage have fear of activity because the activity induces dyspnea. So psychological support, education, and behavioral changes are important. The goal of pulmonary rehabilitation is not only to improve the patient's physical and mental condition, but also help the patient return to the family, society, and more promptly. Next slide. Next. Next. Now assessment. Now, we should assess the patient before rehabilitation. So, what should we see to the patient? These are some of the tests we should perform categorically to assess the present condition of the patient, both how severe it is and whether we should start the rehabilitation program or we should what should we do first, or at which level we should start. There is a breath hold test. It is usually we ask patient to hold the breath. Normally, a healthy person can hold it for 30 seconds, but the patient whose lungs is affected, they do it much shorter duration, and it indicates if the severity and breathing capacity and others. 3-minute step test is a exercise tolerance test, and you see in the slide that with this test we are monitoring the heartbeat, uh, change in the oxygen saturation, and uh, uh, the symptoms appearance, that is dyspnea. Then posture change on bed, that is the posture change on bed, getting up from bed, squatting. These are the postural movements, and it requires both the trunk muscle strength and of course the limb muscle, especially the lower limb proximal muscle. And these are the large muscles where the activity of them increases oxygen demand, and the capability of patient and the uh, capability of this respiratory system can be assessed by this test. And then the functional independence, we can assess the patient daily activity, how much he is independent or can perform the work. Next slide, please. Next slide.
Next slide.
Next slide.
Dear moderator, please go for the next slide.
Then we should also assess the breathing capacity. Some points are related, that is whether there is cough, the patient has active dyspnea, exertion, fall in SpO2 and other symptoms. Capacity of the limb trunk muscles, that is that I have already mentioned. Slide, please. Khosru.
Dr. Khosru, please proceed for the next slide.
Khosru.
Is he not online?
I think someone should call him. He's possibly from this.
Over the line, take a video, sir.
আমার মনে হয় হ্যাঁ ও খসরু ডিসকানেক্টেড হয়ে গেছে।
স্পিকার আমার মনে হচ্ছে স্পিকার আপনি কন্টিনিউ করেন।
হ্যাঁ কন্টিনিউ করো, এটা
প্লিজ কিপ অন টকিং, ইউ প্লিজ কিপ অন টকিং।
ওকে প্রফেসর মুনিরুল, you please continue.
Okay. Actually, I have presented here 3 cases, the 3 case history, and these 3 cases. One is very mild involvement of lungs, and one was moderate to severe involvement, and another was severe involvement. The case 1, it was moderate one. The patient age 56, male, diabetic, controlled, hypertensive, previous history of respiratory disease. He has got COPD and he was smoker, but he left smoking 2 years back. He has a massive involvement of left lung, but right lung was not that much involved. He was in ICU for 21 days. But now when we started the program, he was in the cabin. So he has got a breath hold test of 11 to 13 seconds. 3 minutes step test he could perform, but SpO2 falls to 85%. Dyspnea 3, pulse reaches 2. Next slide. Next slide. Next one. Yes. You can see that he has got agetta. Next one. Yes, this one. ঠিক আছে এটাই এর আগেরটা এটা না, এটা এর আগেরটা প্রিভিয়াস স্লাইড, এর আগেরটা। হ্যাঁ, ইয়েস, ঠিক আছে, এটাই। You can see the patient has got more on 3-minute step test. The patient has moderate dyspnea with mostly spontaneous recovery and but sometimes he requires oxygen. Recovery time is about 40 to 70 seconds. Posture change, squat and prolonged sitting cause fall in SpO2 from 90 to 88%. Mild dyspnea with spontaneous recovery time for recovery. Recovery time is 30 to 35 seconds. Independent in self-care, but some activity and repetition of others causes fall in SpO2 to 90 to 85%. Mild to moderate dyspnea, mostly spontaneous recovery, occasionally requires oxygen. Recovery time 30 to 70 minutes. These are his conditions before treatment, before when we start treatment. Then, but the next one, case 2, it was a mild involvement. It is a case of mild involvement. Age 64, male, diabetic and hypertensive. Both control, no previous history of respiratory disease. Multiple rounded consolidation in both lung was found in CT scan. Patient was in COVID ward for 7 days, needed oxygen for few days, and breath hold test was 18 to 22 seconds. 93 to 91%. Pulse reaches to 104 per minute. Mild dyspnea with spontaneous recovery. No need of oxygen. Posture change and prolonged sitting cause no symptoms. No falling SpO2 in this case. In posture change and prolonged sitting. Independent in self-care and most of other activities. Some activity causes mild dyspnea with spontaneous recovery on rest. Next. This is also his findings before treatment. Next. Thank you. This is the case 3. It is it is also a male patient, 52 years, diabetic, hypertensive, and he was an active smoker. Previous history of respiratory disease and massive involvement of both lungs. Patient was in ICU for 26 days. Now in cabin, requires oxygen inhalation. His oxygen dependence was then breath hold test was 2 to 4 seconds. 3-minute step test unable to perform. Squat unable to perform. Dependent on in most of the ADL activities, and attempt to perform the other of those causes fall in SpO2 to 85 to 80%. When he attempted to do the other activities, recovery from decreased saturation requires oxygen. Recovery time is 2 to 3 minutes with oxygen. Next. So, before we start talking about the rehabilitation, we should know the goals of the program. The first goal is to limit the increase of oxygen in the side. This can be any activity where we are strong enough. There will be less increase of oxygen demand. Activity modification, that is for the less control training. Muscle control training is goal to increase the trunk muscle and limb muscles and trunk muscle. Both can be strengthened to minimize the oxygen demand induced by the exercise. To increase the exercise tolerance, number 2 is to increase the exercise tolerance to gradual increase in the aerobic exercise capacity. Then to increase the breathing capacity through exercise of the respiratory and accessory respiratory muscles. And now, next slide, please. Next slide. So, next slide. Now, the general instruction should be followed in the program. Number 1, exercise. Ageta. Previous slide. Go. Previous slide. Yes. Exercise induced fall in oxygen saturation should never reach below 85. So it should be a target saturation level that will indicate discontinuing of the exercise. So we should stop the exercise when this target saturation is reached. Oxygen saturation should be monitored before, during, and after each of the following procedures, if possible. Measure the duration of the exercise and the time of the time to restore oxygen saturation after the exercise induced fall. Actually, these are the practical parameters with which we can assess the improvement of the patient to a very small scale, and we can also detect the difficulties of the patient during the procedure. Increase in duration of the exercise and decrease in the time of restoration of the normal oxygen saturation is a sign of improvement. Next slide, please. Next slide. Now, specific rehabilitation plan. So we, according to those ideas, we have discussed in previous two slides, we should go for a specific rehabilitation plan that will include, number one, the strengthening of the peripheral muscles. That can be done by the exercise. Then improvement of the improvement in maintaining the change of posture. So we can do it by posture control movement, 2 to 5 repetitions, or improvement of the exercise. These exercises, it can be done in the pulses when patient has got limited exercise capacity. After a pulse, patient should have the rest. When every parameters are normal, then say he should attempt again for another pulse, and the number of pulse should be detected very individually by the patient according to the condition of the patient. Improvement of the breathing capacity. Improved breathing capacity can be done by the repeating deep breathing exercises for 5 to 10 times, or according to the condition of the patient, it may be less or more, at least 2 or 3 sittings, and it may be increased gradually. Then with the improvement of the patient, of course, other exercise of chest and abdominal muscles should be done to strengthen the accessory muscles. Clearing the excess. Then number 6 is number 5 is clearing the excess lung secretion. Excess lung secretion, for this we can take the advantage of the postural drainage, and this can be enhanced by the manual stimulation with gravity, and the mechanical stimulation by manually or by any instrument like vibrator. Then improvement of the function. So patient should be trained functionally to be improved for his improve his independence, and this can be facilitated by activity modification and environmental modification when the actual biomechanical improvement is less. Next slide. Next slide. Now, for individual prescription, we have 3 patients. You can have a overall idea about the approach of this patient. This is the case one, is the moderate one. Here we can specific to his condition. That I see muscle only 5 repetitions twice a day. At first, it was the first prescription when we started, and according to the assessment we have previously shown. And equipment, we should need a pulse oximeter so that we saturation throughout the procedure. Then postural control movement to improvement these also given very at first. It should go for increasing it with the improvement of the patient. Then aerobic exercise. Patient initially, this patient could walk for a few minutes was only 4 to 5 minutes, and his pulse was detected accordingly. And you see there we have prescribed only 3 pulses in 2 sittings daily. And breathing exercise, repeating deep breathing exercises for 6 times in 2 sittings. This is also possible for him at this stage. And postural drainage at 1 sitting, taking actually this patient who has not very um, uh, very uh, productive cough at this stage, but this uh, drainage, there was some productive, some sputum which was uh, disturbing him, and the postural drainage once daily was sufficient for him for the condition. Some activity modification, the functional training, we found some essential, some of his self-care activity with some modification he could proceed with at this stage. Next slide. This is the case 2. The case 2, you see, his case 2 was much mild in his symptom and involvement. So we are a bit advanced to prescribe him, and he will not need everything in that stage, because he was functionally almost independent, but some difficulties were there. So isometric active exercises of spinal and proximal limb muscles was given. Postural control movements was given 8 repetitions, which was gradually increased. Aerobic exercise walking was started with 10 to 15 minutes, and he do not need a pulse. We started 10 to 15 minutes in 2 sittings, and it was gradually increased, and he could go with it. And breathing exercise, repeating deep breathing exercise for 3 times in 2 sittings, and other exercise of chest and abdominal muscles was also given. Postural drainage was given, but he needed it not. He needed it for a few days only, and then he did not need the postural drainage anymore. Next slide. Individual patient case 3. In case 3, it was very difficult for us to he could not perform the postural control movement and the aerobic exercise at first, but he could do it after postural control movement after 1 week, and the aerobic exercise he could perform after 2 weeks. So initially he was given the spinal and proximal limb muscle exercises, and breathing exercise, repeating deep breathing exercise. It was given initially, but probably he after doing these exercises, his saturation fell, and he invariably needed oxygen at first stage for for recovery, and the recovery time was longer in case of him. But in the subsequent follow-up, it was seen that he could all of these parameters improve. Next. Now the follow-up. Here we have just summarized the parameters, improvement of the parameters. In case 1, you see on 8th day, after 7 days of the program, the postural maintenance and change improved 50%. After 15 days, it is 70%, and after 22nd day, it is almost 90% improvement. Exercise tolerance also gradually improved. Breathing capacity, exertional dyspnea, and the functional independence was this is very steady improvement in this case, and it was very nice because when we started, he was very much dependent. Very much dependent, but not. Next. And now the case 2. The case 2 was a mild involvement. Here we see the improvement is much faster and much complete in his in this case. Next slide. But in case of case 3, here we see the improvement is much slower and lower, but there is clear improvement, and within 3 weeks, the patient is not completely independent and completely free of respiratory problems, but his improvement is remarkable. So we hope that if he continues the program further, he will get the complete normal life. Next slide. So the summary of our experience. Our experience is very limited experience with very few patients, and the disease is also very very new, and the total situation of the scenario is a different scenario with a pandemic environment. Still, we can say that pulmonary rehabilitation is beneficial and necessary for both treatment and prevention of lung movement involvement in COVID-19 patients. The recovered patients of COVID-19 with lung movement involvement has become a major challenge for medical staff. The resolution of which requires rehabilitative treatment with multidisciplinary collaboration and joint exploration so that evidence-based high-quality support can be provided. Pulmonary rehabilitation should be provided throughout the disease management process, regardless of whether the patient is in the hospital or at home. Next. Individual patients should be assessed specifically, and rehabilitation prescriptions should be individualized based on the patient's specific condition. The effective incorporation of pulmonary rehabilitation into disease management and a patient's daily life can provide long-term benefits to both the patient and his or her family. Implementation of the both traditional and research-based pulmonary rehabilitation provides valuable experience to clinical and rehabilitation medicine practices. Next. Here you can see a satisfied patient after successful pulmonary rehab. He has almost to he could gain almost to his normal life with the final rehabilitation program. Thank you.
Dr. Moshiur Rahman Khosru, please moderate the question and answer session, and then we will be moving towards the opinion from our expert along with us, who are present with us. Dr. Moshiur Rahman Khosru. Dr. Moshiur Rahman Khosru, can you hear me? Well, among the present audience and here.
Thank you, sir, for giving me the opportunity to moderate the session. Now, may I request all the audience for the participants to ask for any question or comment before thereafter we'll move for the comments from the panel of experts. And please, if you have any question, please you can unmute your microphone and ask the question.
Hello.
Hello.
Yes, please. Dr. Abdul Rahim, please, you can ask your question.
Assalamu alaikum. Thank you for brilliant presentation, sir. My question is regarding the parameter of improvement. Is the parameter of improvement it is I mean for the all cases the parameter of improvement is fixed for according to a protocol, or this is the first visit that is recorded for the parameter of improvement.
Thank you, Dr. Rahim. Actually, there is not and there is no widespread and accepted protocol so far for COVID-19 rehabilitation. You know, it is the condition, actual clinical reality, but clinical scenario is understood for a few months. And I have seen one Chinese guideline, but here I have the parameters I have mentioned. Many of them are in the guideline also, but some points I have added myself with my clinical and practical needs. Actually, especially the recovery time. When I have seen that the patients are very much in fear that exercise can make them much worse again. So after exercise, when the after exercise, when the oxygen saturation falls, the patient become panic. So we have to reassure them, and when they take rest and sometimes oxygen, and they recover to the normal oxygen level. They have been, their panic is gone away, and this when we see that when this recovery occurs immediately or with smaller time, with a much limited time, the patient has been more assured. So I think this was my idea that recovery time, when the recovery time is decreasing, it is a sign of improvement of the patient. So this is my my assumption. If it is proved by many other experiences, many other studies, then it can come to the protocol also. So we have not widely accepted protocol, international or national protocol so far. Today, Dr. Moniruzaman has sent me a rough copy of national protocol, proposed national protocol. I didn't got the time, but this to look at it. But here I have just mentioned about my experiences, and when I face a patient and I face the practical problems, these protocol, these points came out of my practical experience.
So thank you, sir. Now may I ask Dr. Fazil Rabbi Choudhury, he raised his hand. Do you have any question or comment, please? Dr. Rabbi.
Yes, thank you very much. Thank you, the organizer, for this nice meeting. I have learned many things today. So my question is to sir is what is the ideal time to start respiratory physiotherapy, like using a respirometer? What is the earliest possible time when a patient could start that?
Actually, we should assess the patient. There is not fixed time for that. It is dependent on the condition of the specific patient. If we want to start it for specific patient, at least we should convince him first that he will try. If it is we cannot convince him, he is not qualified. Number two, he will assess the effect of the he will start doing. We should monitor the his heart rate, oxygen saturation, and other physical and psychological condition. If we think, we clinically think that he could do it at least some low level, so he should do it some low level, and when the parameters goes down, and he should be stopped, and again he should recover and try to do it. And with this, but if he can do it at very low level, but he do not do it, the performance will not improve. So this is the idea. It should go very low and very slow, but it should start as soon as possible.
Thank you, sir. Thank you very much.
May I ask one question, sir? Sure, I have one question. Is COVID-19 is a very contagious disease, and pulmonary rehabilitation, particularly pulmonary exercise, breathing exercise, is aerosol producing. And what is your recommendation to start pulmonary rehabilitation or breathing exercise at the stage of active viruses? That means when it can be contaminated, that means within first 2 weeks, how it can be studied. It should be studied in person, or it can be studied in video or in other with the use of technologies. What is your suggestion? How we can proceed?
Okay. Regarding the today's discussion, we are discussing our experience with the post-COVID patient, because when we started, these patients are already negative. These patients are already negative for the COVID virus. So, and still, after being negative, many patients are there with a much difficulty in respiratory performance, and of course with the functional level. But in case of the active patients, actually, I think, which is not in within this discussion, I think, but relevant with this discussion. But so far you have asked, this is my opinion, that the for prevention and the improvement of the patients with active disease, I think already our COVID team, those who are working, they are doing their doing it. So far, it is recommended that the positioning, postural training, and the breathing exercise is done by the doctors and nurses of the active COVID unit, and patients are getting it. So there is no contraindication to do it. It should be. I have also mentioned that this is both for treating and preventing the lung condition, this lung dysfunction or lung damage. So we should do it in the active phase, and should be done by the physicians and the nurses. And after the patient become negative, then I think the rehabilitation team should be okay. Thank you.
So thank you, sir. Successfully, I
Dr.
would like to put the same question. Yes, sir. Sir Muzaffar, sir.
Yes. I have a question to Dr. Professor Morul Islam. During the assessment of the patient, because many of the functions of the lung has been compromised, and the alveolar ventilation, pulmonary ventilation is been damaged or damaged or interrupted. So, is there any role of us seeing like simple respiratory FEV1 and VC capacity, FEV1 and vital capacity to be monitored during this disease process?
Yes, this can be introduced in our total assessment protocol. But
yes.
Since we have not introduced it, and our assessment is totally clinical. But if we have the facilities of spirometry and other respiratory investigations, these can be routinely introduced as in the protocol, and then in that case we should have much larger multidisciplinary approach, I think.
Thank you, sir.
Thank you.
Sir, I would like to put the same question in another way to the panel of experts, particularly to Professor and Chairman Department of Internal Medicine, who is conducting COVID unit. Sir, do you think that pulmonary rehabilitation and psychotherapy should be incorporated in COVID management guideline, particularly in acute stage, so that we can improve or to prevent pulmonary function from the very beginning? And one thing is very concerned to the health professionals, that's the personal safety. I think when we are wearing personal safety equipment in our practice, and I think it is possible to give in-person rehabilitation service as well, along with other acute management care. So I will like to get answers from all the panel of experts regarding these issues as well. So if you don't have any more question, may I request Dr. Ali Imran, who is asked me to for his comment. May I request Dr. Ali Imran?
Dr. Khosru,
Sir?
I like you, after having the comment from Dr. Ali Imran, you please ask our multidisciplinary experts from respiratory medicine.
Yes, I will ask. I will ask them, sir.
We like to talk to them also.
Their
Yes,
opinion is very important, right?
Yes.
Right.
Yes, sir.
Opinion of the expert is very important.
Yes, sir.
Sure. Dr. Ali Imran.
Thank you, sir. Thank you for giving me the chance. Actually, my comment is very simple. No question here. Very simple comments. Number one, I believe still it is very premature to comment anything decisive regarding COVID right at the moment, because it is a novel virus. Just 6 or 7 months has elapsed. We are familiar with this virus. Those virus or bacterium which are known to us for hundreds of years together, still new information are coming every day, and it is a new virus. So I think it is yet very premature to comment anything decisive. But what is already proved is prevention is the best management of it. I would like to enlighten on 2 points. Number one, who are already affected with COVID. Number two is who are not affected. From my discipline, who are already affected COVID, please go to a hospital and have the management, because now many management protocols have been established, particularly in BSMMU, and those who are not yet affected with COVID, they are in the bad dilemma of many things. Number one, their lifestyle is badly modified. They are confined themselves within a few square feet of their very few square feet of their apartments. Their normal lifestyle has been badly reorganized so that it has got a physical impacts on them without having COVID. So they need some rehabilitation protocols. I like to enlighten on that. Please keep your body mobile. Please keep your lung functional. Just having these 2 protocols, you can be very much physically active, though you are not affected with COVID. How you can make yourself active? Just do normal physical exercise. All joints of your body should be carried through full range of motion. কিছুই না, আপনার শরীরের প্রতিটি জয়েন্টকে আপনি দিনে 2 থেকে 3 বার পূর্ণ মাত্রায় মুভ করাবেন। এটাই আপনাকে যথেষ্ট সুস্থ রাখবে। আর দ্বিতীয়টি হচ্ছে ব্রিদিং এক্সারসাইজ। ওই লট হ্যাভ নোন অ্যাবাউট ইট। এনি সোশ্যাল মিডিয়া আপনি এটা চেক করতে পারেন, আপনি দেখতে পারেন। এই ব্রিদিং এক্সারসাইজটা আপনাকে অনেকখানি ভালো রাখবে। সেকেন্ড ওয়ান ইজ prevention, and I should say, in fine, we are left nothing but prevention, and it can be achieved. I believe the world is also thinking. So 4 personal activities and 2 national activities. The personal activities, try to use a good quality mask, not N95 or something like that. Good quality mask, number 1. Number 2, please maintain social distance. It is at least 2 meters. It has been proved. Number 3, please perform hand hygiene. আমরা জানি কিভাবে করতে হবে। সব সময় স্যানিটাইজার দরকার নেই, ভালো মানের কাপড় কাচার সাবান। Number 4 is please maintain coughing and sneezing etiquette. It is very important. And the other 2 is left with the state, with the institutes, with the medical colleges. That is, detect the case by testing and isolate them. Number 2 is contact the trace and quarantine them. I think in a nutshell, this is best for COVID prevention and COVID treatment. Still it is under trials. Many authorities are formulating many protocols, and all the electronic, printed, and most of the social media are now flooded with COVID information. The pandemic is becoming an infodemic. Everybody is flooded with much more information. So I should say it is the best is prevention, which can be achieved through your personal activities. Just maintain these 4 things. Keep yourself active physically by doing some minimum physical activities, exercise, and some breathing activities. Thank you very much. Thank you for arranging such an academic activity. Thank you.
Thank you, Adi Imran. Professor Sohail Mahmood Arafat, we like to have comment from you. We are eagerly waiting. And before you start your comment, I'd like to ask one question. What are the chances of getting pulmonary idiopathic fibrosis or interstitial lung disease in this post-COVID patient? Professor Arafat.
Thank you, sir, Professor Saleh. At the very beginning, I'd like to appreciate my thanks and gratitude to the cardiopulmonary rehab group, which is really important and play important part in this COVID era. I also like to thank Dr. Khosrow and all the learned panelists who are in front. My senior professor, Professor A.K. Musharraf Hussain, he's the perfect person to answer this question anyway. As you have asked, my answer is that regarding the pulmonary fibrosis, as already Dr. Ali Imran has said, it is just a beginning of the coronavirus. This is just a novel virus, even we don't know what is really going on. If we compare with the previous ones like SARS viruses, which is also coronavirus, that's time also many persons have developed lung sort of fibrosis or some restriction of the lung functions. But fortunately, after years passing together for long years, after 9 years, almost all of them have recovered. Regarding coronavirus, can you hear me? Okay.
Yes.
Okay. So regarding coronavirus, that depends on the involvement of the lungs. There is a lot of cases, almost 80%, 90%, 75% lungs are involved. So we have to follow these patients because there is damage to the alveolar walls, there is inflammations, there is clottings. So a lot of things happens to the lungs. So these injured tissues or damaged tissues might be replaced by some fibrous tissues. So for this purpose, to be honest, in different parts, especially in UK, they are going for long-term follow-up of those patients. They are recalled to the pulmonary rehab centers. They are reassessed by lung function test, whether they are going to do some permanent damage. So still, it's not the time to mature enough to say, but there is strong chance of there's some remnant lesions in the lungs after severe COVID. We have to be very watchful. We have to encourage the rehabs. We have to encourage the respiratory function at the earliest stage, so that few medications like steroids, something might help to stop the process of fibrosis. Regarding that so nice topic, pulmonary rehabilitation. Yes, it's to be honest, in our parts of this world, it is relatively, neglected part. In our day-to-day practice, even in other pulmonary conditions, it is not that much popular, or we have failed to make it popular or useful to our patients. So regarding COVID-19, definitely there is a lot of pulmonary insults. So regarding pulmonary rehab, we have to think it is an acute, subacute, and long-term. In all steps, put this patient severely ill, might be ICU admitted. So in that case, even we have to do some pulmonary rehab. If there is acute in the worst, but he is not admitted ICU, whose oxygen is low, they also need some pulmonary exercise or pulmonary rehab. Long term, of course. Regarding rehabilitation, there is one concern. I think there's some background noise. Anyway, there is one concern that it is a high infection disease. So in person, in all the cases, it's not possible. What we can do, we can advise some printed documents.
Excuse me, those who are not talking, please mute your microphone. Please. Those who are not talking, please unmute their microphone.
Khosrow, please mute all participants, then that will be fine. Okay, so regarding acute and severely ill patients in ICU, Definitely there is physical, but in the acute setup in the wards, we can educate our patients by duty doctors by doing some leaflets or pamphlets or some posters so that they can practice inside the room, because already that is said that might generate some aerosols that might cause infection in or at least in our setting, because in one room there is few patients, their attendants. So these sort of things might cause some problem. Another important issue is what is about the ICU patients when they are released from the ICUs. There is one term that is called post-intensive care syndrome. So that PICS, and that PICS really matter of rehabs. That rehabs is not only pulmonary, that not only physical, that is cognitive, that is psychosocial. That is another neglected issue in our common practice. So that should be a multidisciplinary approach of rehabilitation for those patients who are suffering from severe COVID disease, who have fortunately could leave the ICU and back to normal life. So these few things we have to keep an eye. We have to just not the physical, we have to do some psychosocial, also cognitive functions. Another issue is this in this COVID time, our respected learned physical medicine specialist. So can there any option of development of some sort of telemedicine type of physiotherapy? So that means rehabilitation or home-based rehabilitation. Because in these days, it will be very difficult for those persons to visit you in person, or for you as well, difficult to do the in-person rehabilitation program among them. So from your forum, you can develop some sort of telemedicine type of pulmonary. That is also possible. That is also possible because if you make some group like this, you can educate your patients. You can make a session of pulmonary rehabilitation among the targeted populations. So from my side, yes, I have to answer Dr. Khosu what he has raised the question. Definitely, we have to incorporate some sort of pulmonary rehabilitation in acute admissions, as well as also for ICU admitted patients when they are suffering from active COVID disease. That is also part and should be a part of our treatment guidelines. That is because otherwise we'll lose the patient due to the muscular weakness that will cause a more respiratory embarrassment or something so on. So with this few words, I'd like to appreciate my thanks again to the learned audience. I've learned a lot from Professor Monirul Islam. My regards goes to him because we have learned a lot really, day to practice. It might help to us some extent. Thank you. Assalamu alaikum.
Thank you. Thank you, Professor Musharraf. Thank you, Arafat. Professor Monirul Khan, would you please like to say something?
Yes, I have a question to Professor Arafat. What is your experience regarding our COVID management patient at BSMM?
Professor Arafat.
Sir, thank you, sir.
What is your experience?
Thank you, Professor Monirul Khan. Experience is from different paths. If we go for 360-degree experience, different. As a physician, as a caregiver, as an other part of the patient sides and the management for many issues.
Are you satisfied?
Satisfied never till we die. Life is never to be satisfied 100%. We have to go a lot of things because it is a matter of system. But I must appreciate our junior fellows, doctors, and other consultants from different specialty. I want to salute them. I want to salute them because really they are courageous. They are very brave. At very beginning, I was a little bit pessimistic because I was thinking that the junior doctors might not be so much brave enough to do their jobs. But I'm really surprised. I must appreciate their real braveheart approach. And also my fellow, consultants from different disciplines, not aside respiratory medicine or internal medicine, even from surgery faculty. They are going to the rounds, they are giving the service. That is a really eye-opener because our doctors are really good. If they are given the opportunity, they can serve. So that is the positive frame of mind we have, we possess, which is hidden because that is not exposed. So that is the real I appreciate. Number two, regarding the service. Yes, we have in BSMU service especially, we lack the acute medicine care. By the presence of COVID-19 pandemic and opening of our COVID unit, we are really dealing with many critical acute cases by our doctors. So they are handling not that bad. They are really doing good. Yes, we have got a mortality around 10%, till today. Because of that, because BSNU usually caters only the severe COVID patients. Usually the 90% severe COVID. So among severe COVID patients, it's not unexpected to have some higher rate of deaths if we compare with others. So I think so. Regarding the management issue, also we are doing good because still there is some few loops and holes, but that is we are on the way to mend those gaps. So we hope, and I'm really satisfied till today, not 100%. If you 100%, we will have to end the journey. So we are really satisfied, and possibly we are going and doing better and better day to day. So hopefully that's not bad. Regarding management is fine. Alhamdulillah, it's good. With our cooperation with our respective pulmonologist specialist, our other colleagues, I am satisfied with it. Thank you, sir.
Now, I like to hear something from Professor A.K. Musharraf Hussain.
This is our call. Phone.
Professor A.K. Musharraf Hussain.
Yes.
I'd like to hear from you regarding your experience in this.
About what?
Your experience in
about what?
core member of the COVID care in the BSMMU, and your comments on the pulmonary rehabilitation in the post-COVID patient.
So first of all, I congratulate Speaker Professor Munirul Islam for his very detailed and illuminating speech and his very laborious delivery in spite of some technical faults. And this is definitely new, and he has enlightened us with a lot of new things, and we learned a lot of things from his lecture. And if I go for pulmonary rehab first, though we say this is pulmonary rehab, but this is actually rehabilitation of a patient. Well, lung is organ. So we have to rehabilitate the patient as a whole, the all organ of a patient, and the lung will be rehabilitated. I think in this way. When I think of pulmonary rehab, I feel very much frustrated. So far I know that if you plan pulmonary rehabilitation for a respiratory patient, especially COPD or other chronic respiratory illness, you will not find any place to refer, including the tertiary medical college and etc. And we know that we can arrange this pulmonary rehabilitation at 3 levels, starting from hospital setting, then you will give follow-up at outpatient setting, then you will continue to maintain the improvement at home setting. And this is a very, very structured program, which we do not do. And the extension of pulmonary rehabilitation is much more. It includes even the diet, the nutrition, the smoking cessation, the oxygen therapy. And I get very much disturbed and frustrated when I see my colleagues are much more important about instrumental rehabilitation than the simple general exercise training to make the muscle strong, to improve the exercise capacity. They don't believe on the active cycle breathing technique for postural drainage. They believe in vibrator. I don't know what is the reason. So these are few things actually we have to think ourselves, and we have to improve ourselves. We have to do a lot of things. If I think to treat a case of COPD, the first thing in the prescription and pulmonary rehabilitation, it should be smoking cessation. I find no center in Bangladesh a complete smoking cessation program. So this is the present scenario, and I am very much sorry to say all these things in front of all the big shots who are working in the tertiary level, and they always actually shrug their shoulder that we are doing a lot of things in the improvement of medical science. Coming back to COVID-19, very rightly, actually, we are at a very premature level to say. But of course, right now we are having about 2 lakhs patients who are having severe pneumonia and critical pneumonia. They will have definitely some chronic lung disease in the form of fibrosis. Some may develop bronchiectasis, a lot of things. And the recommendation is like that when you discharge a patient, you have to keep these patients for a pretty long time. And I think, I don't know whether you have gone through the paper, which is in the online of JAMA network. Just 2 days ago, I saw this paper, the persistence of acute COVID-19 symptoms. And they have included about 30,000 patients of Italy, and they have followed up those cases 2 months later of discharge. And it is seen still 2 months later, 80% patient has fatigue. So you can understand the morbidity of COVID-19. And definitely, COVID-19 will have a very critical burden on the physical medicine and also respiratory physician about their rehabilitation for a pretty long time. What happened if we look back in SARS and MERS cases as well. And as I was asked by the chair to say about my experience in COVID-19 management, considering the total management, I am very happy. I am very happy. And I believe very much that in spite of all the flows in Bangladesh regarding scarcity of manpower, scarcity of financial ability, scarcity of beds, ventilators, I do not feel that I have to beg anything from outside to manage our patients. I need not buy the antiviral drugs, the remdesivir, which is the most important drug in the management of severe COVID-19 pneumonia. We are a manufacturer. We don't have any scarcity of ventilator. We don't have any scarcity of manpower right now, and we have contained the infection very much with mortality just 1% and above. And I salute the COVID martyrs, about 92 martyrs, doctors who died of COVID-19 in treating COVID-19 patients. First of all, I remember and salute Dr. Lee, who first said the outbreak for which he was present. And still, I pay my respect who are working as the frontliners to manage COVID at all levels. I believe each and every doctors at government or non-government level, 80,000 doctors, Bangladesh, are working to fight against COVID, to win against COVID. And I believe that we have already won the COVID-19 situation at every level. This is my belief. Thank you very much for giving me the opportunity to speak in this plenary session, and very valuable and honorable participants, guests, and thank you, Chairman, Moderator, Moshir Rahman Khusru, and once again, thank you, the speaker, Mr. Munirul Islam.
Thank you, Dr. Musharraf. Now I'd like to hear from Professor Harisul Haq. Please, sir.
Salim bhai, I have to retreat. Because of shortage of charges and my screen will be shut very soon.
Okay, sorry, Professor Harisul.
Thank you very much.
Very short, please short.
Short. Okay, everyone is talking too much. Well, thank you very much, Professor Munirul Islam, for his brilliant lecture. So many thanks to Professor Musharraf, Professor Sual Muhammad Arafat for their learned, very much valuable speech. Okay, I just tell a scenario. A doctor of Bangabandhu Sheikh Mujib Medical University was caught by COVID-19 just 3 months ago. He developed severe limb weakness and dementia, delirium, and psychological problem. Okay, and he diagnosed as a case of polyneuropathy as well as psychiatric problem. Okay. That means I just want that we need some rehabilitation. Professor Dr. Khusru was telling about this. Psychological rehabilitation as well as the initial rehabilitation. It may be the muscular, lungs, heart, everything is required. One question has been arising by Dr. Ali Imran, that when to start the rehabilitation program. As far as my knowledge goes, in ICU setting, even in the stage of hemorrhagic stress, it is the stage that if early rehabilitation started at the very early stage, that is very good. In this stage, I can conclude that basic exercise can be started, vibrator can be started as early as possible. Otherwise, serious complication like the polyneuropathy may occur. Okay, I think that the heart and lung is very much close, that the cousin organs. If lung is damaged, then pulmonary hypertension will be ensues, and this is why cardiomyopathy will be occurred there. So, as a cardiologist, I need a stronger and very good healthy lung just to save the heart. So, thank you very much. As because 2.5% of the COVID patient, when they infect with the COVID-19 and become a case of arrhythmia, which is secondary to chest infection or secondary to lobar pneumonia, then subsequently develop acute MI. Otherwise, on the other hand, coagulopathy, which results from the endothelial dysfunction, it is also very important thing. So I think that if we can rehabilitate the patient and the muscular exercise can be started very soon, including heparin injection, then we can prevent the death from the COVID-19 as a result of pulmonary thromboembolism. Thank you very much for giving me the chance to say something. Thank you again.
Thank you, Professor Haris. Professor Syed Muzaffar Ahmed, you are running out of time. Please do make
Hello, Mr. Chairman.
Carry
Hello,
on.
Mr. Chairman.
We are listening.
Oh yeah, yes. I must with his listen to the speaker was initiated, imposed a new theme or dimension about the management of the about the management of the patient with pulmonary rehabilitation. Hello. I must thank panel experts ranging from Professor Hussain, Professor Arafat, Professor Harslop, Professor Morujaman, Professor Ahmed, and Dr. Imran, and other participants, viewers who are attending to our session. Actually, this is important in your thought because of pulmonary rehabilitation. That is the main target organ of this COVID-19 disease, and causing death of the several millions of patients in the countries who are affected throughout the world. So rehabilitation is an important chapter that we should consider from the earliest of the disease. Earliest of the disease has a symptom. So Professor Moshour has told that it should be meticulously imposing over the patients, either normal patients or COVID patients. So rehab management is very important for improve the pulmonary functions and to improve the psychological and social aspects of the disease, because patients are dying due to pulmonary dysfunction or pulmonary organ failure. So pulmonary is a very is a scintillating matter for the patients suffering from this COVID-19 disease. So I must thank Professor Sholbam Arafat. He has delighted so many things, and Professor Harsullah and Professor Moshour Hossain has already mentioned the importance of the pulmonary rehabilitation in management of COVID. That has stirred our minds, and we'll think about the pulmonary rehabilitation from the initiation of the disease, but the onset of the disease, because to keep the pulmonary functions, to keep the alveolar functions properly, we have got some breathing exercises, so protocol exercises, so many ambulatory measures, even simple breathing, even simple exercising, simple exercising, but aerobic exercise may compensate the burden of disease of COVID-19 diseases. So I think I must thank this panel for the giving time, expanding time, despite the busy schedule, to cling to this session. So at the again, I must thank the panel experts again for the patient sharing and to attend this new thoughts or dimension of pulmonary rehabilitation, and that is stirred our mind that we must go through the rehabilitation approach in patients of COVID, either mild, moderate, or even severe patients. I'm very much happy to join this function, and I'm getting retirement from this session because shortage of my charge, and my skin will be very short. Very soon my skin will be short. This shortage of that. I must thank everybody for the patient sharing. Thank you very much.
Thank you, sir. I'm extremely sorry that I was out of net for a few minutes, and I'm extremely sorry for that. If you allow, then may I ask?
Taslim, please next. Let him talk to next.
Exactly.
Professor Taslimuddin. Professor Taslimuddin, sir, we'd like to hear from you.
Okay, thank you so much. Thank you, Cardiopulmonary Rehabilitation Group. Thank you, Mr. Chairman, Mr. Moderator, participants, and the panelists. The speaker has very elaborately expressed the experiences shared for 3 cases of pulmonary rehabilitation. And there have been some queries and concerns like when to start rehabilitation for pulmonary patients, and what is the PICS, as Professor Sohail Arafat also mentioned this. To me, why rehabilitation, when rehabilitation, and how rehabilitation? These are the 3 issues for pulmonary rehabilitation. As we know, the pulmonary and the COVID-19 issues are emerging. Still, every day we are learning the things, and we are treating the patients. At the same time, we also need to protect ourselves, our healthcare workers, and rehabilitation workers as well. So, if I answer you why rehabilitation, rehabilitation is for impaired lung function, for physical deconditioning and muscle weakness, for cognitive impairments, for impaired swallowing function, and for communication, and also for psychological supports. See, the patients, COVID-19 patients suffer with respiratory problems, musculoskeletal problems, neurological problems, and also cardiac problems. So whenever we assess a patient and when we approach to a patient for rehabilitation, we have to assess as a total case. So when to start? Actually, rehabilitation is a continuum of care, starting from critical care. As we stage the COVID-19 patients into 4-5 stages, critical care, see, our experience is not that heavy. Actually, what happens, out of 10 patients in ICU, 9 patients are expiring. This is our experience. There may be some experiences otherwise, but why these patients we are losing? Is it that we are not caring the patient adequately, or there is any shortage of the care? So if rehabilitation can be started early in the continuum, I think that can help. How that can help to improve the condition for early discharge and clearing of the bed, because this is a difficult period. We need more beds, especially in the critical care situations. So it is much required. At the same time, when early rehabilitation started, we need to also protect our other patients, and at the same time, rehabilitation healthcare workers for aerosol generation and other things we need to also take into consideration. And how rehabilitation, the speaker is elaborated already these issues. You see, Professor Musharraf Hussain and Sohail Mahmood Arafat also mentioned these issues. Rehabilitation is a teamwork, and it is dependent on some of the instruments and appliances. Just not with a person can do all these things. And we are really deficient of manpower and also the appliances. We do not have many appliances that we really need. And also, at the same time, we also need some your spaces. Without space, you cannot have a rehabilitation. And when the patient is sustained at the critical care, we need to patient sent to the next what I should say, step down care. I mean HDU, and then to take more patient in the critical care situation. And so this step down care and long-term care at the home or in the community needs really planning and support of rehabilitation services, what we do not have in our country. This is, I'm sorry to say, we need to have government, private, public partnership these works to support rehabilitation, because in our perspective, rehabilitation is not taken as a health priority like other acute care specialties. So with these few words, I want to thank you all. And because these cardiopulmonary rehabilitation and COVID-19 issues are really emerging every day, and we are learning, we need to keep on eyes. We need to learn more and more every day. So to serve the nation, so to serve the people of Bangladesh. Thank you so much.
Thank you, Professor Taslim. Next, I like to invite Professor Shahzad Hussain Ripon. He's a very important part of our group, and he's the Secretary General of the Bangladesh Association of Society for Physical and Rehabilitation Medicine. Please add your comments to the forum.
Thank you, sir. Today's chairperson, Dr. Etienne Khalid, sir, and also the keynote speaker, panel of experts, and the multidisciplinary experts, and also the participants. Assalamu alaikum. I am also the chief coordinator of COVID unit in Swiss College. So, in my personal experience, I say something about the COVID and its post-COVID rehabilitation. When a patient comes to our COVID unit, it is most important that during this period, we have some intervention, rehabilitative intervention, especially posture, proning, and these are the most, we try to these things for the patient with some leaflets and with some board in the ward, in our ward, and with some exercises, deep breathing exercises, which also important in that period. We give it with board and like that, and we follow the patient like we must know who needs the post-COVID rehabilitation, because the patient who have especially severe disease, who need more than 10 liter oxygen and also need high flow nasal cannula or ICU, the patient who are elderly, and the patient who have comorbidities, especially who have previously compromised respiratory disease, and sometimes some mild and moderate disease COVID patients also have chronic fatigue syndrome, and we must follow these patients in the ward and who need more oxygen, and we also follow the CT scan and X-ray finding who have more lung involvement during this process. And we also involve our physiotherapists in our COVID duties, one in every team. And we rehabilitate in patients also. And when we discharge the patient, we try to educate the patient about the rehabilitation. Also, our inpatient is also open. When these post-COVID patients, especially who need high flow nasal cannula, severe diseases, and also critical conditions in ICU, because we see that these patients, most of the COVID patients have not put on productive cough. They are dry cough, but some 30% have productive cough, and they have need sometimes post COVID situation need postural drainage also. And especially, I think that when patient is recovering, especially after ICU and after severe diseases, when patient have oxygen demand is high, when patient is recovering, I think that there is severe fatigue, and the rehabilitation process must be in gradually. Sometimes patient, when patient recovering, they try to do more exercise and they try to do more work. And we see that when patient is recovering phase, when they go to the toilet and they do some exercises so early, they have need again oxygen, and again the patient is deteriorating. So follow the patient and assess the patient and rehabilitate the patient. That is our speaker said elaborately, that it is a gradual process with a rehabilitation specialist if we provide it. And also this time, psychological support is almost important, because sometimes I see that sometimes husband and wife also infected with COVID at a time, and we admit at a time in a same setting or closed bed, I see that patients are more compliant than other patients because they each other psychologically support each other, and we encourage them, and they do the rehabilitation process with each other. And this time, I think that we use incentive spirometry, this post-COVID patient, which gradually with incentive spirometry, this is also, we provide the patient, and we sometimes provide, sometimes they buy it, and with this incentive spirometry, patient do it, and gradually when he or she is improved, then we discharge him. So we do these things practically in our study. I think that when the patient is discharged, we follow up the patient sometimes in our rehabilitation, physical medicine and rehabilitation. Also, sometimes they follow up with telephonic with telephone. We try to build up a booklet for them when they are discharged. I think this is also helpful for them. So with these few words, and also thanks the organizer to organize such a multidisciplinary webinar, and also thanks again our keynote speaker who delivered excellently, and also our especially multidisciplinary experts who are from internal medicine and respiratory medicine. I learned a lot from them. Thank you all.
Thank you, Dr. Shahadat Hossain. Now I will ask Professor Moniruzzaman Khan to say his part of comments. Professor Moniruzzaman Khan, please.
বললাম তো একবার respected chairman, honorable professors and participants, especially Professor Monirul Islam for his nice and brilliant presentation. Thank you, Monir. Actually, we learned a lot from your lecture. Expected high burden of respiratory, physical, and psychological impairment from post-COVID patients. A huge number of patients need immediate refer to rehabilitation unit. Pulmonary rehabilitation are equally important for both admitted and discharged COVID patients. Usually the symptoms are very mild: fever, cough, dyspnea, and myalgia, but few cases may rapidly progress to acute respiratory distress syndrome, and few to cardiac and kidney injury, for which our respected Professor Arafat, Professor Harisul Haq, and Professor Musharraf Hossain are ready to manage and settle these cases. The aim of pulmonary rehabilitation early goal is to elevate dyspnea and remove anxiety and depression, and prolonged goal is to accelerate the his or her in the society as early as possible. So thank you everyone, especially thanks to Professor Arafat, Sohail Mahmood Arafat, for his taking the leadership to treat the COVID patient at Bangabandhu Sheikh Mujib Medical University. And এখন আমার একটা কোশ্চেন আছে বাংলায় সালেক ভাইয়ের কাছে। সোহেল মাহমুদ আরাফাত আমার কাছে একটা প্রাইভেট নোটিশ পাঠাইছেন যে where is our lemonade and where is our webinar food? As chairman, you should answer this question. Thank you.
Will be provided later on. These all are used. Though I cannot feed you, you can just make the movements that you are being fed, but it will be done later.
Okay, thank you, dear chairman.
Everybody, we are fine. Let Allah.
sir.
Yes, sir. Please. Sohail bolo.
বললাম যে প্রথমত হচ্ছে যে না, এটা প্রাইভেট মেসেজ ডিসক্লোজ করা ঠিক হয় না, কপিরাইট ব্রেক হলো 1 নাম্বার। 2 নাম্বার হচ্ছে গিয়ে আমার লিডারশিপে না, সবাই মিলে হচ্ছে, কোনো লিডার নাই, সবাই মিলে
যাক আমরা শেষের দিকে চলে আসছি। Let us proceed and thank you.
আপনার ইয়ে পেলে আমি একটা স্যার অ্যানাউন্সমেন্ট ছোট দিতে চাই স্যার, আপনি যদি অ্যালাউ করেন।
অ্যানাউন্সমেন্ট আমি শেষ করে দিচ্ছি প্লিজ।
স্যার অ্যানাউন্সমেন্টটা হলো যে এই ওয়েবিনারটি আয়োজন হয়েছে কার্ডিওপালমোনারি রিহ্যাবিলিটেশন স্টাডিজ গ্রুপ। এটি নামটি নতুন এবং মানে এটি একটি ওয়ার্কিং গ্রুপ, জাস্ট আমরা যারা রিসার্চ করতে চাই এই বিষয়ে তাদের একটা প্ল্যাটফর্ম তৈরি করা হয়েছে। মূলত উদ্যোগটা হচ্ছেন হারিসুল হক স্যারের, হার্ট ফেলিউর ম্যানেজমেন্ট নিয়ে স্যার এবং স্যারের ইউনিটে ডক্টর খালেদ ওরা বারবার আমাদের সাথে যোগাযোগ করেছে এবং আমি জাস্ট হাম্বল থ্যাঙ্কস জানাই, গ্র্যাটিটিউড জানাই হারিসুল হক স্যার এবং তার ইউনিটকে, যে তারা আসলে হার্ট ফেলিউর এবং কার্ডিয়াক পেশেন্টের রিহ্যাবিলিটেশন ব্যাপারে যে এমফাসিস দিয়েছেন সেই বিষয়ে, এবং সেখান থেকে শুরু করে আসলে যেহেতু হার্ট লাংকে আলাদা করে করা আসলে খুব কঠিন, সেই বিবেচনাই হলো যে স্টাডি গ্রুপে তৈরি হয়েছে এবং জাস্ট এটার উপর এমফাসিস দিয়েছেন মোশাররফ স্যার। স্যারের সাথে যখন কথা হয় স্যার বলেছেন মানে এটা আসলে ডায়ার নিড একটা বিষয়। সো আমি সবাইকে ধন্যবাদ জানাই এবং সবার কাছে উদাত্ত আহ্বান জানাবো, যদিও একটা বঙ্গবন্ধুতে এই একাডেমিক গ্রুপটা শুরু হয়েছে, ইউ অল আর মানে কর্ডিয়ালি ওয়েলকাম, এবং আমরা যদি সবাই একসাথে কাজ করি, আমার ধারণা যে যেহেতু আমাদের আসলে কোনো ন্যাশনাল গাইডলাইন নাই, কোনো কিছুর গাইডলাইন নাই, না হার্ট ফেলিউরের রিহ্যাবের গাইডলাইন আছে না, আমরা সবাই মিলে কাজ করলে নিশ্চয়ই একটি মানে পেশেন্টের জন্য, আমার সোসাইটির জন্য, সায়েন্সের জন্য কন্ট্রিবিউট করা যাবে। থ্যাংক ইউ ভেরি মাচ। আর এই প্রোগ্রামটি সায়েন্টিফিক পার্টনার হলো ACI।
Thank you, Dr. Khosru. We are at the end of the session, so we have learned a lot. এবং আমাদের অনেকের কাছ থেকে শোনা হয়নি, we are sorry for that. I think we will keep continuing arranging this type of webinar, and we will be further those who are working on the cardiopulmonary rehab, we can later also weeks later we can have another webinar to have their new experiences and their follow-up cases. So I like to thank firstly the organizers and then the sponsor ACI and all the participants. Not about 50% participated in the session. All in all, now already we are having about 40 participants right now to the end. So after 2-hour long discussion, everybody is tired somehow. Some yet to have their dinner, late dinner. So we are going to finish. Professor Harisul, thank you for your kind. You always talk for the cardiac rehabilitation, and cardiopulmonary disease cannot be separated. It's true, lung and heart cannot be separated. So thoracic or cardiopulmonary all come together. And rehabilitation in a nutshell makes it, we all know, not only the lung, not only the cardiac side, not only the kidney, not the liver, muscle, nerve, and all the body should be rehabilitated. And in our from physical to the body ailments, everything happens. So in a nutshell, we have to keep the patient back to their normal life as soon as possible. And rehabilitation process from our speaker, what we can understand that it should start from right from the very beginning. Then maybe it can be divided into the acute rehab, and later on it be shifted to the chronic rehab. But rehabilitation should go side by side from the very beginning. So with care, you should give the rehabilitation in the early setup, and later on we can go for the but rehabilitation should be side by side from the very beginning. So thank you everybody. Thank you for your participation, for your comments, and lastly the Professor Munir Islam for his painstaking to produce these slides and for his lecture. And I like to thank everybody and for and we'll hope to meet again. With this hope, I like to conclude the session. Thank you all. Assalamu alaikum.
Thank you, sir. Thank you, sir. Allah Hafiz.
Thank you very much. Good night.
আমাদের সবাইকে ভালো রাখে, সহি সালামত রাখে, এইটার ওয়েবিনারের ফুড সবার কাছে সবার পাওনা রইল আর কি।
Thank you.
Thank you.
হাজির বিরিয়ানি নিচ্ছি সালেক, হাজির বিরিয়ানি।
আচ্ছা, আল্লাহ বাঁচায় রাখে, দেখা যাবে।
আমি যারা লাইভ করছেন, লাইভের দায়িত্বে যারা আছেন তারা এটা এখন অফ করে দেন, লাইভ আউট করে দেন, তারপরে কথা বলি।
ওকে।
For the live